I've had apologies for absence from Councillor Kennedy and Helen Woodland, who's our Adult Social Care Director. I've had apologies for lateness from Councillor Garcia and Councillor Sanatar. There's other training events going on this evening. Councillor Adams tells me they are on their way. Because we have got quite a few members of people in the room, what I suggest is everybody in the room can see who is online, but everybody online doesn't know who is in the room. So I'm going to do a quick round. Councillor Hayhurst, Chair, and go around this way.
Councillor Turbet-Delof and Mental Health Champion.
Chris Lovett, Deputy Director of Public Health, City Hackney.
Danny Burton, Public Health Registrar.
Jed Francique, Borough Director for City and Hackney for East London Foundation Trust.
Laura Pascal from Hackney Labour Women's Declaration and the Women's Rights Network.
Annabeth First, Policy and Strategic Delivery Officer.
Sarah Creighton, Sexual Health Consultant at Homerton Hospital.
Jonathan Laura Security Officer.
Councillor Sharon Patrick, Vice Chair.
Councillor Adams, Member. Thank you. I haven't been notified of any urgent items. This is a hybrid meeting. It is being recorded. Sometimes members of the press are watching it. It's being live streamed live. For those online, please mute yourself when you're not speaking. Please don't start conversations in the chat. When it is your item, please keep your cameras on. If you would like to make a comment or get my attention or contribute and you're online, please raise your electronic hand. Declarations of interest from members. I haven't been. Councillor Sanatar.
Yeah, sorry for jumping in late. I was in another training, but just to say that I work for City and Hackney Mind.
Thank you, Councillor Sanatar. That's duly noted. So I'm then going to move on to the first item on the agenda, which is item 4, health inequalities and medical barriers faced by the trans and non-binary community. This is something that we were asked to look into by full council when a motion was passed a few months ago on this area. We were due to be joined by Tara English from a charity called Gentle Intelligence, but due to work pressures, they are unable to attend this evening. We're grateful for Dr Coyne and Dr Creighton from the Homerton to be with us. Also Dr Paul Gilluley, who is going to speak from a North East London level, and also Helen Wyatt, who's the practice nurse at Lower Clapton. And I do also understand there may be further contributions from further colleagues at the Homerton. Heggy, I see you've got your hand up.
Yeah, it's just to say I'm not a practice nurse, I'm an advanced nurse practitioner. It's a minor difference, but yeah, my real name, just for transparency, is Helena, so if anybody wanted to look me up, but I'm known as Heggy.
Thanks, Heggy. Just before we start, I think to start with, I was going to go to Dr Coyne or Dr Creighton to sort of start the presentation. We've got two fairly brief presentations in the pack, and we've also got the strategic framework, the LBGTQIA+ strategic framework. As I understand, that's been put in for reference, and we're joined by Emmy, who's helped or responsible for drafting that. As I understand it, that is going to Cabinet on the 24th of July, and then we go out to formal consultation. So that was there for reference. We have had, I know Laura has, who's here, has made some observations on that, as has Councillor Troughton. My suggestion, because that is not formally before us, those aspects, I know you've got another question there, Laura, as well, that I'll sort of ask Public Health as well, but the sort of specific question to do with the strategic framework, my suggestion is, post that going to the Cabinet, it then goes out to consultation. I encourage those observations that have been made to get fed into that consultation. I can see already that there's a variance of views on aspects of it, and it may well be also that I speak to Councillor Gordon, and possibly with the suggestion that it may even come before scrutiny panel at the point that it is out for, or one of the scrutiny forums at the point when the consultation has actually commenced. I don't want to shut out everyone's different views or observations on that, so I don't want to close that down but it's not being presented on tonight. So specific observations on that, I'm going to suggest maybe the consultation, and then maybe we review whether it can go before another panel at the point that it's out for consultation. Can I then start off? Dr. Creighton, were you going to lead off from a sort of from a Homerton perspective, and then?
Okay, certainly. I'd first of all like to start off by saying I'm not an expert in this field at all. I had assumed that gendered intelligence would be talking about the social, psychological, political aspects of it. I am a physician. My main area comes from medical prescribing. That's most of what I can talk about here. I also have a child who is a transgender woman, so I can talk a little bit from one individual's medical perspective from that. If I'm doing a bit of the job of gendered intelligence, what I would say is that there are many, many well-adjusted, completely sorted transgender individuals, but the health and social outcomes for the transgender population as a whole are significantly worse than most other disenfranchised groups. The outcome, they are, as soon as you come up with numbers, they can be disputed. The numbers are in Europe are 80 to 20 times more likely to die of external causes than other groups. They are more likely to be the victims of violent crime, significantly more likely to be the survivors of domestic violence and intimate partner violence. They are less likely to engage with health and social care agendas. Transgender men are extremely unlikely to engage with antenatal care or necessary contraception. So my starting point is, whatever your viewpoint around other disenfranchised groups and the impact of health inequalities on those groups, here is a small population, very small population, but with extremely vulnerable, disenfranchised, poor healthcare outcomes, and we can improve services significantly for them. And I would say that as a politician, as healthcare individuals, things that we can do to make things fairer, we can look at. The areas that I know about are around medical prescribing. That is what my area of expertise is. I'm sure that everybody here is aware of the significant gap in commissioning for transgender services. To get an NHS employed adult, and that's what I'm talking about, I'm not talking about people under 18 here, but there's a 5-year waiting list for NHS services. The adolescent services, as people may be aware, have been currently closed pending decommissioning at the moment. People, young adults or any adults, facing a 5-year waiting list, a time that they're establishing their identity and establishing who they understandably go private or they self-source or self-medicate. Trying to get a reputable private source for we have to remember, I'm a sexual health consultant. If my child found it difficult, and I'm accepting and I'm supportive, I shudder to think what other transgender individuals are facing. The first few hits on the internet are for some services that are being struck off from the GMC that are operating from outside of Europe. To get a reputable private transgender thought, there was an 8-month waiting list even for paying private, and I have to say how heavy my heart goes when I'm saying to people that we paid private, as an NHS consultant, that we have to pay privately. Even faced with that afterwards, trying to access the medication that are recommended, there are significant barriers there. We, for most of the time, could not get it prescribed from our GP or within the NHS for self-source. There's I can talk about the details of that now. I thought that I knew the medication. They're medication that as a sexual health consultant I'm using all the time. In fact, as soon as I look into the details of them, the dosage is so unusual for many of the medications that they were even paid privately on the internet trying to get a reputable source for these was something that was extraordinarily challenging. I have to say that myself accessing the medication via the internet was something that horrified me, what I had to go through from there. There are a range of NHS services, as I say, for NHS gender identity services, there's a 5-year waiting list. For sexual health services that can make things less dangerous, so needle exchanges so that you're not at risk of infections, help with interpreting blood results and so on and so forth. There's one in Chelsea that operates once a week. There's one in the King's College Hospital. There's none in North East London. These services are very oversubscribed. They have people travelling from all over the country just for the damage limitation side of things, but access to sexual health, contraception, and needle exchanges and things like that. They do offer what they call bridging letters, advice to GPs this is what we recommend, and these are very evidence-based. There are guidelines that I've put the links to in there, describing what dosage should be used, what monitoring should be done. But even with the bridging letters and with an extremely good local Hackney GP from both NHS sources, from Chelsea or King's, or from the private sources, local GPs were extremely loath to prescribe the medication. Okay. It feels like I've spoken a lot about medication, about NHS services, so I'll stop there, but I do have other comments to make later on.
Thank you. What I'll do, I'll go through the presenters and I'll open it up, and then maybe members have some questions. Then open it up to broader conversation. Dr. Coyne, did you want to make any further observations from a Homerton perspective? Dr. Coyne?
Sorry, I was trying to unmute. I can hear you. Thank you very much. No, I haven't got anything to add to Sarah's comments. Thank you.
Thank you. I mean, then can I probably neatly go on to Dr. Paul Gilluley? And sorry, I may have mispronounced your.
Yeah, don't worry.
I apologise. So, I mean, Dr. Creighton's point was very much in terms of the difficulty of the waiting list and the commissioning side of it, which is where you sort of perhaps more neatly fit in as the Chief Medical Officer for NHS North East London. So could you maybe give your observations broadly on the subject, but also on that commissioning framework?
Yeah, so my name is Dr. Paul Gilluley. I pronouns he and him. I'm a consultant forensic psychiatrist, and I'm the Chief Medical Officer at NHS North East London, which is the new integrated care system. I fully support everything that Dr. Creighton has said regarding the inequalities we have for the transgender community. And one of the main aims of actually the ICS is to address those inequalities for our populations regarding access, experience and outcomes. And it's one of the things that's major on my agenda. Can I just clarify though how services are commissioned? So gender identity clinics that Dr. Creighton talks about that are get 5-year waiting list. She is absolutely correct, and it's absolutely ridiculous that they do have. But these are the specialist mental health commissioned, and that's a national basis. So they're not commissioned by the ICS themselves. They're commissioned at a national service. I'm not saying that's an excuse, but just to say that the commissioning for gender identity clinics lies at a national baseline. And the other bit is in the sexual health clinics are local authority commissioned. Now that is due up to be reviewed on the local authorities. So I think there is some work there we can do with the local authority commission, because there is a NEL joint commissioning to work to.
Oh, we've lost you there. You're frozen. Paul, just if it helps on the upload speed, maybe if you turn your camera off and just keep your microphone on. We've lost him mid-flow.
Could he log in again?
Paul, if you can hear me, maybe log out and log back in. And Sandra, not to put you on the spot, but seeing as Paul just left off on possibly joint work with local commissioning, and I appreciate Paul hadn't quite finished what he was saying. What are your observations on that? And I fully appreciate, you know, we know this as councillors, you've got incredible budget pressures coming down the line. But is there any greater scope of local commissioning with local authorities on this?
Yeah, the short answer is yes, and you've got Chris in the room who can probably give you a lot more detail because he's the lead consultant on sexual health. We've just developed a new sexual health strategy, which draft strategy is out for consultation imminently. I think the key issue for commissioning services for people who are transgender is that we actually have very poor data about the numbers and the specific needs, and we can go into that in more detail later, because I do think it's an important issue for us really understanding the needs and the scope of, and as well as the range size, if that's the right way of putting it, of services require, or specific service requirements, which are not specifically to do with being transgender, but just making sure that you have appropriate and equitable and sensitive access to services, the same sort of services everybody else needs. I see that Dr Gilluley's back, but if you wanted to get a bit more detail about the North East London collaborative agreement around sexual health commissioning, Chris can give you a lot more detail.
I'll come to Chris in a minute. Dr Gilluley, what we just did is, because just before you froze, you just mentioned about joint working with local authorities. So hence I thought to Dr Husbands at that point. But please carry on.
So I think I'd like to move on to some of the things that was raised in the gender intelligence report. There is an issue about GPs prescribing hormones, as Dr Creighton laid out. What we're trying to do within North East London is to get some specialist training in regarding prescribing hormones for a group of specialist GPs who could be to start off with one GP per borough or one GP per place, and who would be the specialist GP who we could refer to for advice and for hormone treatment, either by following a private assessment, or the other thing is when people are sitting on the waiting list for so long, who would benefit from treatment with hormones that can actually prescribe them there and has that specialist knowledge. Dr Creighton mentioned about, you know, the challenge there is in prescribing hormones and the doses and how to get that balance right, and also the monitoring that's associated with that. But we're outsourcing that at the moment, and I'm in discussion with Dr Camilla Cameron, who's a trans GP who worked in the area before, to talk to her coming back to give that training to our GP specialists. There's also discussion of other staff within primary healthcare being appropriately trained in how to the issues, trans issues within the primary healthcare itself. That is actually available already within our training hubs, so that there is training for primary healthcare staff in these issues for our primary healthcare staff. As also we mentioned about the other thing that I just want to mention as well is I'm involved with the LGBT Foundation and the Pride in Practice, which we're trying to get into North East London. Pride in Practice is an LGBTQ aware practice accreditation scheme, which kind of looks at practice and makes sure that they approach the LGBTQ plus community in an appropriate way. And there's grading from bronze, silver, and gold. It's worked really well in the north of England and also in southeast London, but we've yet to get a practice, I think, accredited in northeast London. But I'd like to try and get that established through our inequalities funding, and then we can spread that through northeast London.
And Paul, just before we leave off with you, so do you roughly know, we've said it's a 5-year wait, how many people, say, in City of Hackney are on the waiting list, or across North East London at any one given point, given the 5-year wait?
I don't have that off the top of my head, but we were looking at they were looking at that nationally the other week, and there was problems with the data, so I can try and get the data back for you.
Yeah, I mean, I think it would just be interesting to know the numbers in terms of CCN.
And the one thing we're concentrating tonight in adults. I know there was a lot of talk about the cash report, but we really I thought tonight is really we're concentrating in adults, transgender inequalities, the children transgender inequalities. There's a whole issue with the cash report and implementation of the cash report.
Yeah, no, I think we are focusing. We've got a Children and Young Persons Scrutiny Commission here, and so we are focusing on the adult aspect. Thank you very much for that explanation, in particular where the commissioning responsibility lies. Can I then move on to Heggie from Lower Clapton for a more perspective from the GP practice?
Hi, yes, thanks. Just to mention, I'm by background an anthropology graduate, and gender is a useful reflecting point within that undergraduate study. Worked in Brazil, where they have different definitions of gender, especially in indigenous populations where I worked. I have a niece who's trans and a cousin's son who's also trans, so I've had that more recent insight as well into people's experiences. We have quite a number of people who are trans on our patient list. I think partly because we're a welcoming practice. We've been we're open and inclusive. There are lots of complexities, and I think I'm very, very happy to hear that the training hubs have developed some good training courses, because there has been an absence of that. Gendered Intelligence have had some excellent sessions with experts by experience presenting, which I've been to, and learned a lot, and being able to share that with my local team, but not across obviously the ICS. I think we need to think outside hormone treatment as well. Hormone treatment is extremely important, partly because it's done unsafely at the moment, as Sarah was saying. You know, the online massive doses, scary stuff going on, putting people at really high risk. But there's also issues like contraception, which Sarah mentioned briefly, preconceptual care for trans men who are not dysphoric about their uterus, you know, who might want to get pregnant. People don't remember preconceptual care, and that's a GP, that's primary care. People don't remember appropriate contraception. People don't remember necessarily bleeding, unwanted bleeding when people are on HRT, trans people. People don't remember gamete storage, fertility protection. These all need to be considered before people start buying things on the internet. And they're not widely properly discussed. And gamete protection, there is a little bit of muddle about people's eligibility for that. And again, timescales can get very muddled and put people's fertility at risk later in their lives when we're talking about young people starting their transition journey. The prescribing guidelines, we all know, are a bit of a mess, partly because we all prescribe. When I'm prescribing, I prescribe within my competence, as do all my GP colleagues and other prescribing colleagues. And the guidelines are currently that we need an expert to have said and assess the patient properly with proper clinical expert background before we prescribe. And I think that's absolutely right. I think that's safe and appropriate. I think we all need to be trained experts, becoming more widely accepted as a normal, natural thing that we do, in the same way as we do for postmenopausal women. We prescribe all the time for postmenopausal women who are identifying as premenopausal women. That, you know, I mean, you could go into these political discussions all the way along, but we already prescribe hormones for a lot of our patients for a number of different reasons. So we are experts in prescribing hormones for different indications. The other things I noticed in terms of welcoming people in primary care are the basics. What what do people choose as their title? You know, that's been quite a difficult message to get through to reception teams when people are registering patients. MX is much more acceptable. I've actually managed to change my, I'm a woman, but I've managed to change my title on our clinical software to MX. I'm very pleased about that because it's irrelevant. But our patients should be allowed to do that however they identify. There are very good guidelines in some surgeries that I've managed to dig up off the internet about how to register people, how to, before they've got their gender recognition certificate, about what people can do to change names, which is perfectly fine, but people have come up across obstacles when they're accessing care, which is totally unnecessary. It's an admin problem, it's not a clinical problem. So again, it's across the team training about being welcoming, making access sympathetic and appropriate, and maintaining equality and equity and comfort and respect. So these are all things that we address in our practice with difficulty. It's challenging. There is more recently quite a little bit of the gender critical, whatever that means, politics going around that people hear, people who are non-clinical staff hear and respond to, unless they're adequately trained to reflect and respect. So there are lots of different aspects in terms of equity of access, apart from providing medicines, which is really, really important. But it's complicated, and we all need training across all of those issues that I've mentioned. And you know, if I could just go back to the gamete storage and fertility protection, that would be really nice to have clarity at ICS regarding that. I'm quite happy to answer questions for clarity. I know that was a bit of a rant.
No, thanks, Peggy. That's very valuable. Just before I sort of then throw it out for a wider discussion, just to ask you then, in terms of training of reception staff and those admin processes, what have you done at Lower Clapton to sort of put that into place? And then, do you think you've advanced there that could be spread out to other PCNs, or is it still in progress?
Yeah, so it's not a formal thing. It's all about nudging. It's all about saying, you know, you can do this, a little bit of an email if we've noticed something that's gone a bit wonky in terms of equity of access or preferred names, that sort of thing. But no, we haven't done anything formal as far as I know, but it is something that I'd like to move forward on when I've got time. But yeah, it's been nudges. The other thing is to have somebody in the practice. At the moment, the reason I'm here is because I'm the person who people talk to. So my GP colleagues may come to me to ask, just because I have a particular interest. So have a person of reference in the practice who's interested, who's a little bit knowledgeable. I'm not an expert. I think that's a really, really important thing in terms of, you know, medicine, as we always say, medicine's too big for one person. It should all be about teamwork. It should all be about people having their own interests, and those interests being known to the rest of the team and being a resource for our colleagues.
Thanks, Peggy. I've got further questions, but I would like to open up to other members first before I sort of, I don't want to dominate too much. So any other questions? Cllr Turbet-Delof?
Thank you very, very much for your presentations and reports. I guess my main concern, I work primarily or heavily with migrant communities, and we have had recently cases of 2 residents who were self-medicating. It's also our residents that are on very low income, and in one of the cases, you know, really choosing not even to eat to buy the medication. Concerns that I would like to hear, you know, where there is support, but also regulation of this self-medication bottom line. Is there such a thing? Can there be one? And what is happening in Hackney in terms of this? Thank you.
Yeah, so in terms of whether there's regulation of what's bought online, no, the internet's an open market. There are some NHS UK provision of, for example, estrogen, which is used for postmenopausal women. You can get that from a relatively reputable source, but you can get many things in a completely unregulated way. I agree that there is a big concern about how people are funding private healthcare and all of the very expensive aspects of trans health. There are very high incidences of prostitution and the dangers involved as a result of this. There are very, very good detailed guidelines produced. There's the World WPATH guidelines, there's some UK-based guidelines. There are things that are relatively easy to follow. In terms of the reception staff, again, the GMC and the Medical Association have produced some standards that people should be adhering to. So there are things there that could be adopted, but they're not mainstreamed at the moment.
And in terms of people from different communities, I mean, is some of those reference points, is it in different languages in terms of?
So the guidelines I'm talking to are aimed at clinicians and professionals. They're not necessarily aimed at service users.
Just say someone looking on the internet wouldn't be necessarily anything wise.
No, no. I thought that it was how are professionals going to do safe prescribing?
Yes, I mean, we've been extremely lucky that people like in Spectra, for example, have been extremely helpful. It is difficult to find, and thanks, Chair. I think that there are issues about the language. My concern is that there is little disposable income already on low-paid families. They are already struggling with cost of living crisis. There is inequalities, of course, in the access in terms of the medication that they need. And then that puts them into even more vulnerable situation, losing housing, and the list goes on. But with very little support for the demand. There are great organizations, but the demand is not, it doesn't match the demand.
Absolutely, I completely agree. And I agree with absolutely everything Peggy said about it not being just about hormones. It's also not just about sexual health. The access to routine screening, prostate screening, cervical screening, breast cancer screening, cardiovascular screening, all of that gets lost when the gender identity can change. The NHS numbers don't necessarily match up with the appropriate screening programs. But conversely, there's also what gender intelligence talk about being the transgender broken arm syndrome, that absolutely everything is, this is just because they're transgender. They don't have the access to the same health care that a cis person would do, who's sort of attributed to their trans status.
Councillor Patrick.
Yeah, I don't know who wants to answer to really. You talked about the outcomes for trans people and the poor health outcomes generally, which I've heard about elsewhere, and people not accessing healthcare. And we've heard about some primary care practices not being particularly open, and prejudices amongst GPs, health staff and that. So how can we locally make sure that people can access healthcare safely and feel that they're welcome, if for transition people or people who are transitioning, about their general health, which we've heard is a major worry, because everybody, no matter what their sexuality status, should be able to access healthcare on an equal basis. So what do we need to do to make sure that people feel welcome? I'm sorry, I'm a bit deaf and we haven't got mics, so I thought I heard Dr Gilluley say something about specialist training that was going to be introduced for staff about genders and pronouns and changing names and that. And I just wondered if that was, so when that was going to be rolled out. But I think that needs to be rolled out, but also perhaps we need some training on people putting aside their personal prejudices or disconcern about what people gender are, to make sure that they get healthcare, genuine healthcare for whatever the problem is, whether it's a broken arm, slipped disc, whatever yeah, everybody needs healthcare.
But Paul, do you want to come back on? Do you want to come back on that?
Yeah. So I think there's two bits here. Within the training hubs, my understanding is we're already offering training for staff in primary healthcare regarding trans issues and regarding pronouns, everything that you mentioned there, Councillor. The other thing that I did mention was the LGBT Foundation, which runs an accreditation system called Pride in Practice, which actually goes in and trains practices at being LGBTQ+ aware, and make sure the things like that was raised by Dr Creighton, it's not just hormones, it's about the screening, it's about the treatment, it's treating people and respecting people for who they are, which is a much wider issue and a much wider training issue, and thinking about how we can be much more inclusive for the wider LGBTQ+ community.
And Paul, I can see Councillor Binnie Lubbock wants a question. I'll come to him in a second. But in terms of the rollout of the specialist GP in the place that you referred to, what sort of timescales are we looking at with respect of that? And is there a case for a NEL lead in this area? Because you're here as Chief Medical Officer.
Yes.
Is there a case for somebody that can try and pull these strands together in a working group that meets, at intervals to try and break a map of where who's had training GP-wise? Have we got in place?
So this is what my aim is. So I met Dr Cameron, as I mentioned, who's a trans GP and a specialist in primary healthcare for the trans community. I met her about 4 weeks ago. We're still to get a date in the diary for setting up training. We've identified some GPs who could be trained. As I say, initially we'd start off probably about one per borough, and then they could meet as a group of specialists the whole time and then build up from that. What I'd like to eventually get to is we had a GP or a person like Heggie that's identified within each PCNs. I think, Heggie, your system's right. You know, if you've got somebody within the PCN, within the neighbourhood, that kind of is the specialist in transgender services, then that's what we should be aiming for. But I think we have to start off with GPs who can prescribe first, who would be the point of contact within the boroughs, and we can grow from that. And it is something that I think has to be based at a NEL basis, not at a place basis.
And just one further question. Does the national guidelines allow for GPs at place to prescribe the hormone? Does the national guidance allow for that? Or is it
no, and GPs are not trained to prescribe, but I think that's what GPs are asking for, is that training, so they feel confident in their prescribing. And also what I'd like them to do is not just prescribe because somebody said so, but be able to actually diagnose. Because the problem is, if somebody turns up at your clinic as a GP at your practice and said, you know, I feel that I'm the wrong gender and I want treatment and everything else, as Dr Creighton mentioned, if you're referred to the gender identity clinic, that will take you 5 years. So what happens to them in the meantime? If they've got gender dysphoria and they would benefit from treatment with hormones, who's going to diagnose the gender dysphoria? And we need to think about how we work with mental health services and primary healthcare, that there's some shared practice there that we could really build on. So we prescribe much before waiting to turn up at a gender identity clinic for the appropriate cases.
Right, but you're not prohibited by national guidelines for doing that. It's more of a training and confidence.
My understanding, and it's not my specialist subject, but my understanding of the reason so far is there is no reason why a GP cannot prescribe hormones. As Heggie mentioned, they already prescribe hormones for other groups, but they are not trained or have any training in prescribing hormones, and the guidance is very poor. They don't have the confidence to prescribe hormones, especially when it's not been the assessment's not been done by NHS consultant. They feel very unconfident in it. So what I have to do is, my job as a Chief Medical Officer for covering primary healthcare as well, is think about how do I give the GPs that training to give them confidence that there's a resource within the area that can address our community's needs.
Yes, thank you. I had Councillor Adams next, and I'll go to Councillor Binnie Lubbock.
I think my question has been answered. It's on the prescribing, empowering the GP. What we need to do to actually empower GP to be able to prescribe without automatically referring to the secondary service.
I think you probably have, but I think Heggie wants to come here as well. So if I bring in Heggie, maybe just to make some further observations, then I'll go to Councillor Binnie Lubbock.
Yeah, I was just looking up the actual prescribing guidelines. There are guidelines which say that we can't prescribe unless the person has been seen by a specialist. Yeah, I was just going to pop it into the notes with the, it's we can prescribe what we want, basically, so long as we judge ourselves competent. Yeah. But the guidelines that we feel safe with currently, most of us prescribers are the ones that say that the person really should have been seen by a specialist. If that specialist is a GP in our borough,
yeah,
right,
but that's I think we have to think about the needs of our local residents rather than all these guidances telling us we can't do things when you're sitting in a waiting list for 5 years before you see a specialist. That is unacceptable, absolutely unacceptable, and would be unacceptable under any other condition. So we have to train up our primary healthcare physicians that they're actually able to, wider than physicians, Heggie, sorry, we can be wider than doctors as well, and we can think of other healthcare staff that can prescribe for the population to meet the population, our local residents' needs.
So can I just,
I think Councillor Adams wants to come back in.
I'm just wondering the guidelines. How do we improve on that? We can't just stick with guidelines without moving forward because everything is evolving. And so, what do we need to do to improve on that guidelines to make it more workable for everybody?
Anything further, Paul, to sort of add about? I mean, I think Councillor Adams was just building on in terms of how do you further work on those guidelines to achieve these objectives.
I mean, I suppose the only thing I can say, Councillor, is that we have to keep pressure upwards as well. So we have to keep pressure nationally that actually people are seeing a much more reasonable space of referral, and that we've got the right specialists trained up to provide the care that our local residents require. Now, as I say, that's a national provision at the minute. I cannot actually commission it from the ICS. But in the meantime, what I can do is train up some of our primary healthcare staff to try and address the needs of our local residents.
Thank you. Councillor Binnie Lubbock, thank you for being patient.
Thank you. It's a really interesting talk, and yeah, it'd be interesting to know how sort of quickly that work can progress around training up the local staff to do that. I sort of wanted to follow on from what Councillor Patrick said around welcoming, being a welcoming place. I think one of the things around that is how trans people are represented in sort of outreach and publicity and things like that for general health publicity work. But the other thing, and touching on what Sandra Husbands said around the data, and I think the data is a really big missing piece. And in terms of policy making, if you're not being counted, then you might as well not count. So I'm wondering what we can do locally to try and improve that data picture.
Councillor Binnie Lubbock, Chris Lovett was waving at me just before you started speaking, so I think it's a natural point to bring in there, Chris, on possibly on the data and also what local authorities can do.
So finally, less on the data, but just to expand on sexual health, if I may. So there is evidence that people in trans communities, some people have worse sexual health. We do have excellent local services for sexual health services, and Sarah and Catherine are both here as clinicians who work in the sexual health services. I think it is important that we don't over-sexualise people from the trans community. It is one of the needs, and it's not the only need, but it's been really helpful, I think, to have this well-balanced discussion here. We are very keen to, as part of our sexual health strategy, which is now going out, is out for consultation. So this is for City and Hackney, but there will be a sexual health strategy for North East London as well. If there is the need for a specific trans sexual health service, that's something that we would be very open to looking at. I'm sure that Homerton would be a very natural place for that to be provided on, given the clinicians' expertise and interest in the area. Because we have open access sexual health services, anybody from City and Hackney can go to specialist services that we've been mentioned at the beginning. I think King's and is it Chelsea for the two. And as far as the data, the census has been revolutionary in terms of actually being able to demonstrate the size of our populations across LGBTQIA+. But certainly better data collection would enable us to be more mindful of the differential health needs that are there. So I think in terms of the sexual and reproductive health strategy, it is a very broad strategy that we're looking at in City and Hackney. We've specifically added an additional area that isn't in the other boroughs' strategies around vulnerable populations. And we think that the trans community, trans population, is certainly one of those that would be very keen to explore more. So that in terms of our sexual and reproductive health, and I think a lot of what's been talked about by our GP colleague in terms of the reproductive health needs of the trans community is really important and is understated at the moment in many people's awareness services. So I think once we've got that strategy, we'll be coming back to the Health and Wellbeing Board, I think probably for a small update in September, with an action plan in December, and obviously if scrutiny wanted to bring that in to have a look to see, it would obviously be a natural place for us to talk further about the plans that have been developed there. As far as I think Paul's comments in terms of working with Camilla, I did have the huge pleasure of working with her many years in Tower Hamlets, an absolutely inspirational GP, certainly increased the awareness of trans issues in primary care in Tower Hamlets. If we can bring her in to do some training, I think that would be excellent. And we almost certainly, I think, will be looking at working with the ICB, so that we do have some of the other areas around sexual health and reproductive health better joined up across the local authority and the different parts of the NHS which commission things like sexual assault services, the reproductive health fertility services as well, which I'm sure are all part of the discussions today.
Thanks. Just in practical terms, I think we as councils often see our strategy and we reference the action. Would there be any, is there any scope for any funding to sit behind any of the action elements, or is it more of a, I don't want to diminish it by saying aspirational document, but then, is there money to put behind support actions, or would there be?
I mean, sexual health is one of our largest areas of spend of the public health grant. So we almost certainly will be looking at how, across the 5 years of the strategy, we can make the investments that are needed. You know, there is no new money at the moment, is because the government that we have is not looking to increase inflationary increases for the public health grant. But I think the aspirations that we have for the sexual and reproductive health strategy will come to Cabinet. We will be looking to, for example, HIV treatment and care services will be coming into the ICS. There has been a huge revolution in the ability to provide effective treatment and care for HIV services. So the simple answer is no, we can't commit to more money, but I think we can commit to making sure services do meet the needs of people, and that has always been the case, is that our sexual health services need to be open, accessible. Better data monitoring would almost certainly help. But in terms of a specific service for trans people, that is something I'm very sure across North East London, I suspect we'll get a very similar request from Tower Hamlets and other areas because of the data that we already know from the census. And as I said, because we do have, not wanting to be reductionist, but we do know that there are higher rates of HIV, syphilis, etc., amongst some people in the trans community. And, as well as mental health needs, and we want to be able to make sure that our services are open and accessible and meet those additional needs that we know are there.
And in terms of Councillor Binnie-Lubbock's point, as how we've got the census data, how do we improve upon that in terms of what would be the next step in terms of data collection?
So as I understand it, there is a national NHS data set, which does, the first part is actually making sure that all of the codes are there. So that has been there for some time. I think what you are looking for is giving people confidence in actually being able to share the data as part of the demographics. And I think this is in the action plan that the local authority has in terms of the broader LGBTQIA+. So confidence in actually being able to disclose all of the demographics, and then being very clear as to why and how that data will be used. So I think the census data is really important because for the very first time we have got reasonably granular data that does show places like City and Tower Hamlets and other places in North East London are good places for people to come and live, and clearly much higher numbers than some other areas. But in terms of then seeing, are you getting the level of access that you want into your services, your preventative services and your primary care and your mental health services, that data is not really yet available from the NHS. So it is a little bit of a chicken and an egg that people need to be confident, feel confident to give the data. But at the moment, the data, the fields are there in the NHS national data sets. What you then need is people from both sides. One is to ask, and two is to be prepared to disclose.
And then that would be all the way from primary care, or if somebody visited secondary care. You could pick it up at any stage, presumably. It was just.
I mean, the data on sexual orientation is slightly better recorded in some regards, but at the same time, we very rarely get the data from the NHS because then you have quite small numbers, and there is an issue around actually how comprehensive. I mean, even in the census data, a very large number of people did not choose to disclose. It's difficult to get into why people didn't choose to disclose. It may be that the language was not something that they understood as to how do you identify your gender or your sexual orientation. But actually, it also may be about confidence as well. And I think so. People need to be confident to ask and confident to actually then disclose the information. And we need to be able to show how we use that data effectively to improve services.
Thanks, Chris. Sandra, do you want to add anything there? I saw your hand go up.
I don't think that I really need to add very much. It's really just about the culture of making it clear to people that the information that's collected, that's usually just on a monitoring form and is often detached from clinical records. For instance, when people first sign up with a practice or they attend a clinic, they'll get asked to fill in this form, and if they don't fill it in completely, nobody suggests to them that it might be in their interest to fill it in, and nobody explains what happens to the information. So for characteristics that people feel very sensitive about, either because they don't feel safe or they are concerned about how people will respond to it, they're disinclined to complete them. So we know that people always give their address, for instance, but they won't necessarily give their sexual orientation or their gender or even their ethnicity. And even if they complete the field, it may not be necessarily a reflection of what they really think. So it's important to create that atmosphere of trust that the information is used for good purposes and it's not going to be shared with, say, the Home Office, for instance. And it's that kind of issue. It's the same issue with ethnicity recording as well. There are a lot of gaps in our data, and for all of them, they're getting better, but we still have a populace that's mostly disinclined to trust that people are using these data in a way that is for their benefit and never not for their benefit. And so there's a much wider cultural piece of work that has to be done around creating that trusting culture for the trans community with statutory and actually voluntary services as well.
And is there a common bit of work that the council could do on that to try and encourage greater trust on that area to get a better data set or not?
It's a lot more complex than just doing some comms work, so I get the point, but there is some work that we're starting to do already with local communities to build trust, and I think that and that's everybody across the whole spectrum of ethnicity and gender and age, etc. And in that work, which is relational, because that's trust is relational, that's where we get to have this conversation with people about, among other things, why it's important that they disclose information about themselves and also how we can be trusted, and we can have to demonstrate, of course, that we're trustworthy in what we actually do with the data.
Thanks, Sandra. I had another question.
Sorry. Thank you. Thank you, Dr. Husbands, actually for saying that, because just going to add very quickly, this is a very common issue within migrant communities, that even filling out the census was a major trigger and issue, because there is always a fear that this information will be sent to the Home Office and be reported. And that's why for a very, very long time, you know, we were low in numbers in the census. This time we did, and I'm just adding to what Chair was suggesting, the shift, it will take probably a long time. For us, it was the people that now have documents that felt safe to complete the data. Just that very brief question, which I think you partly answered, and it's around mental health. My concern with mental health is that mental health data is incomplete all the time. But I'm wondering if Hackney is collecting some data on the impact of mental health to the trans community, because all of these inequalities that we're hearing, of course, are life-changing and could be really impactful, not just for the person, but actually intergenerationally for the community. So are we doing any collection on the impact of mental health?
So as Chris was saying, Chris Lovett was saying, there is the opportunity to collect information about people's individual characteristics every time they have contact with health services. And when we can get those data, we do analyse them. But the problem for particularly the trans community is that the numbers are small, and therefore it makes it difficult to draw useful inferences. It would be much better to do that work at, say, a North East London level where we've got some strength in numbers, but we are interested in looking at these. And I think Chris wanted to add something as well.
I mean, just because the census data gives you a baseline, it's by no means, you know, a complete comprehensive set of your LGBTQIA+, but it is actually, for the very first time, does give you a sense of actually how many people are identifying as trans. What I think you can then do is use that in your standard commissioning, because if there is no data recording taking place, you should be getting data recording across all of the protected characteristics. And then you should be just looking just generally, if there's no trans people attending your IAP service, whatever the service is, you know, your mental health service, your sexual health service, or even primary care, that should then be the first question. Well, you know, is the data not being collected? If the data is being collected, why is it not being presented? And that, I think, is one of the strategy areas that you've got the council's potential, that you were saying it is going through. We will go through a consultation, but I think that's a really important first part, is just to see, you know, have you actually got any record of people identifying as trans coming through steps?
So for instance, we know that with our substance misuse services, trans people seem to be massively underrepresented. And it's not that we aren't collecting data about personal characteristics. And so it does appear that people simply aren't disclosing their gender identity. And so it is both a combination of using the data we have, but also doing that work to improve the data collection, because the richer the data set is, the better the conclusions are that you can draw from whatever you do with it.
And so just feeding on that, Paul, is that possibly another strand of work that could be done at NEL level in terms of giving thought to greater data collection or analysis at NEL level for the reasons that have been gone through?
I think there is work we could do at an NEL level. My only slight caution in this is, in the political situation at the moment as well, you must understand that not only are the trans, we talked about the vulnerability of the trans community already, but not only the vulnerability, but what they're facing at the minute and the onslaught from the media is really traumatizing to them again. So actually getting that trust and that identification when they're being daily abated through media and other sources is really a difficult fight for anybody to build that trust. I think sorry, Councillor. The other thing to say was, I think Councillor Binnie Lubbock mentioned about time span for the training up the GPs. I've met with, as I say, Dr Cameron. I've to sort out a date with her. I'm expecting now it'll be in the autumn, so hopefully we can set up that network by the autumn or towards the end of the year. So we should have something in place by the end of the year.
Thank you. And just in the one of the points that was raised by Dr Creighton, that's fully understood. In terms of the ability to get unregulated hormones on the internet, I mean, there are bodies, regulatory bodies, that are meant to approve certain medications or not. So presumably this is, how is this allowed, or does this happen across different areas as well. I mean,
Yes.
because of just the nature of the internet, there's no looking or scaring or clamping down on people who are mis-selling online.
No, it's really difficult with the internet to really regulate any access. As we mentioned, people are going abroad, getting drugs in from abroad, and it's not just hormones, and it's not just the trans community. This is a wider kind of a self-medication issue with our population in general.
Thank you. Are there any? We've got two other items on the agenda. I mean, I'm glad to hear about sort of the progress that's sort of planned in the next year. And sort of one thing that was going through my mind is that maybe we possibly consider, you know, reviewing the progress in the next year to sort of see where we are at place-based level, see where the local consultation is, see whether further GP practices have got accreditation. And it could even be that we take it to the North East London committee level, so we get a greater understanding. Councillor Williams.
I did say that I wasn't going to say anything at this meeting, and I really did come here to listen. My name's Carol Williams. I'm the Cabinet Member with responsibility for equalities and the LBGTQIA strategy. I was really pleased that the council supported the motion, and really pleased that, as chair of the commission, that you've taken up the suggestion very seriously and held this meeting. I'm grateful that I've been able to be in the room to hear the experts talk, but I really did want to put on record my gratitude. I know that residents will also be grateful, as well as our staff. Dr. Paul, you mentioned the vulnerability of the community, and I really wanted to echo that as well, Chair. We have been very careful with our work over the last few years because we understand the vulnerability of the community, because there has been a very toxic media environment. And whilst at the same time as wanting to support the community and ensure that we are discharging our duties to all residents, we also wanted to be careful about how we do that. So I do want to flag that this evening has been a good discussion. It's been a measured discussion, and thank you. I think it's Chris at the end there for saying that we shouldn't be over-sexualising the trans and non-binary community. This isn't about sexual identity. This is about a gender identity. And I do want to just congratulate you all on the tenor of the discussion this evening. I would welcome a review over in a year or so, and if I'm still cabinet leader member, then please do invite me back as well. I'm certain that Emmy would welcome the opportunity, should the Commission want to do so, to participate either formally in the consultation process or informally. There are all sorts of ways for members to do so, and I know that members around this table know exactly how to get involved in council consultation programmes, so please do that. That's all I want to say, Chair. Just wanted to thank you very much.
Thank you, Councillor Williams. So I think for me the only question is whether it may be, if we review in a year, whether in fact it comes back here, or whether it does strike me a lot of this could be driven down, not to put too much of it on Paul's door, but from an NEL level, sort of to do what we can from on a commissioning side. So I propose what I said at the start about, if you've got feedback to the strategy, please make that post the Cabinet's endorsement of consultation. I've got two last hands I saw there before I bring this item to a close. I think I saw, did I see Sandra first, then Councillor Binnie Lubbock? Sandra, do you have anything else?
No, I was just wondering if there was a question that you wanted to be answered.
No, I don't. What I will do, just before I wrap up this, I'll ask members of the public that have come whether they want to pose any questions or whether they want to leave it to the feedback into the consultation. Councillor Binnie Lubbock.
Yeah, I just wanted to add, following on from what was said earlier around having a very different discussion around trans young people, I'm hoping that will be part of the Children and Young People work plan, but that has yet to be confirmed, I think. So, yeah, I really hope we can continue the conversation there as well.
Members of the public, I'm aware they're here. I thought, Laura, do you want to make some observations?
Thank you. I'll be as brief as I can. Councillor Williams' comments about the tenor of the discussion, I think it has been a good discussion, but it's been quite one-sided, and I'm not sure we've heard a gender critical perspective, which is a valid perspective. And just one thing I really wanted to pick up on was this GP diagnosis. I think there seems to be an assumption that the right thing should be that GPs should diagnose and prescribe. You wouldn't be suggesting that for a mental health condition like schizophrenia or all sorts of other conditions. There's a lot of comorbidities that trans people can have. We know with young people, particularly girls, there's a high crossover with autism. It's a serious diagnosis to make, and the consequences of taking cross-sex hormones are significant. They may be right for some people, absolutely. They may not be right for some others, and we have seen some people who are detransitioned, really regretting the effects of testosterone are irreversible. So there's a mental health crisis going on among young people. I appreciate we're not talking about children, but even young adults who may be kind of questioning their gender as part of all sorts of other identity issues, including sexuality. So there's a risk, particularly for young lesbians, being set on a path to transition that will impact the rest of their life, their fertility, life-changing surgery, removing healthy body parts. That is right for some people, but is not right for everybody. So I think that it's not something that should be in general practice. And I think that that's something that perhaps should be considered, rather than just how can we support GPs to do this. The other small point I wanted to make was to pick up on something Cllr Binnie-Lubbock said about if you aren't counted, you can't count. I think we have to be quite careful in all this, all the aim to improve the data, to make sure that we're still collecting data about sex. While we collect data about gender identity, quite often, and this is very much a case on even Hackney job applications, the question about sex is not even included. There's language used about what gender were you assigned at birth, which one has led to problems with the census, people not understanding it, but two, the question of sex not being asked. And while I totally agree that we've got vulnerable trans community who need to be their interests protected, we need to also be careful that while we're doing that, the impact of women and women's health inequalities isn't impacted. So I would just state very strongly that when thinking about data, can we make sure that we're not erasing sex, because sex matters. Thanks.
Thanks, Laura. I think, yeah, I know you've raised other questions as well. Obviously, you can just respond to the consultation on those. I just want to pick up two strands from that before I sort of draw this to a close. Maybe either Heggie or maybe Dr Creighton sort of maybe give their observations on the response to our GPs suitably qualified to give treatment. I know you raised before, you offer treatment or you prescribe treatment for the menopause or the perimenopause in that sort of situation. So I'd be interested to hear your sort of views on appropriately trained that, and also Dr Husbands in terms of the question about still recording sex as well as gender, and what's your view of the health consequences or the importance of that? So Dr Creighton, could I just ask you to go first, and then I'll go to Dr Husbands, and then I'll wrap it up.
Thank you. So yes, I absolutely agree that GPs need to be operating within their competence. They shouldn't be doing anything for which they're not trained, and a major part of our strategy should be ensuring that people have the appropriate training to be delivering the services that they're being asked to do so. But the idea that GPs doing a harm minimisation treatment is going to lead to increased surgery, for example, I don't think that's necessarily what we're proposing. What we're proposing is for people who are making decisions, or making decisions that the GPs have appropriate training to be able to deliver harm minimisation to that group of people. Yes, absolutely, there is a high prevalence of neurodiversity, of mental health issues, and we need people to be able to deal with the various outcomes of it. The direction of causality is difficult to pull apart. What we need is empathic care and trained, supportive individuals who are able to look at things like pain preservation and fertility preservation and have all of these guidelines in place so that they are operating in a functional basis.
Thank you, Dr. President. And Dr. Husbands, in terms of Laura's point, in terms of needing to record sex as well as gender before to get health data from that perspective.
I agree that in the context of a health data set, it's important to record the sex, the underlying sex, if that's the right way of putting it, as well as the gender, for all the reasons we discussed earlier, including making sure that people have access to relevant health screening, and also that in diagnostic terms, doctors and other clinicians aren't looking over certain possibilities because they assume they don't exist any longer because of the gender that someone presents with. But for certain data recording, it may be less important. So I for instance, on the, just to take the Hackney job application example, I'm not really sure why it matters to your employer what your birth assigned sex was, and it should only matter in the context of you having a health issue that may impact the way that you're able to work, and in which case you can have a confidential discussion with occupational health about it, in which case they would record your sex as well, your sex at birth as well as your gender. So I think, I completely agree that that's important. Why it's important to improve the data collection, while it's important to improve the data collection about gender, it's equally important to improve our data collection about all characteristics, because that's how we get a really good understanding, both in a personal sense of what this person needs, but also that we're able to do useful analyses of the whole data set from which we can draw reasonable inferences and conclusions that we can act on.
Thanks, Sandra. I'm going to draw it to a close there. Now, I know, Laura, you would like to come back, but I'm out of time on this, and I've got, most commissioners don't allow questions from the public, and I have, so I try and facilitate as much discussion as I can do. So I am going to draw it to a hard line there. We will either hear, or we will suggest those on the North East London level, we will suggest it's reviewed there. I have had questions from Councillor Shroud, and I spoke to her earlier today with respect to those about feeding back into the strategy, and in terms of explaining we kept it a narrow focus to have a narrow debate. And also, I'll just put on record, some of the officers may be able to reply to some of Councillor Troughton's other observations. So with that, I'll thank everyone very much for a very informative and helpful discussion on this, and it's something that we will keep under review and come back to either here or at NEL level, and please reply to the strategy framework document after it goes through Cabinet on the 24th of July. Thank you. I'll bring that item to a close. I'm now going to move on to item 5, and yes, everyone will speak, please feel free to go, and thank you very much for your attendance. I'm now going to move on to item number 5, which is the response to the quality accounts prepared by the Homerton. We are joined by Breda, nurse for Homerton. Thank you, Breda, for joining us. And I understand Louise has given her apologies, but we're joined by the new Deputy Chief Exec. Congratulations on the appointment, Basrit Sadiq. And apologies if I've mispronounced your name. I think I've got it right. So Basrit or Breda, I don't know who was going to start off with the quality accounts, and then we'll take from there.
Brilliant. Thanks so much, Chair. And apologies, my surname is wrong. So I'm Breda McManus, and I'm the Chief Nurse at the Homerton. I'm taken that the paper is already read, and I'll just give a kind of high level summary and then obviously open out to questions. So as you know, this period covers 22-23 financial year, and we were on a 2-year cycle for our quality priorities. So rather than a yearly set priorities, we've done 2 years, and the safety priorities are around reducing the number of community and hospital attributed pressure ulcers, reducing physical violence and aggression towards our patients and staff, improving the management and reduction of falls. And then we've got one that covers both safe and effective, just culture and a safe environment. And then our clinical priorities around identification and management of our deteriorating patients, and that has been extended to include maternity services, paediatrics and our community services, improving our population health, and the final one being around improving our patients' experience, so the first impressions. So as you will see, we as an organisation have and continue to perform well against the 4-hour ED target. As you know, nationally, the ED target is proving incredibly difficult. So we are still one of the best in the country, but there are a number of challenges around this. Some of those being flow challenges as seen everywhere. So increased complexity and acuity of the patients that we're seeing. Delayed discharges due to social care, both for patients in and out of areas, increased mental health to ED, not necessarily our numbers of mental health patients, but the length of stay has increased for our mental health patients in ED, and also taking additional urgent care mutual aid from the system. So all of this has had an impact on our 4-hour target, but as I said, we continue to review processes and pathways, but we remain one of the best nationally for that. We also continue to meet the standard for monitoring our 7-day services. We've made considerable improvements on the cancer waiting targets across the 2-week and 31-day targets, and we're continuing to look at some improvements around the 62-day target. We have not had any, so our last CQC inspection was in January 2020, but we've recently had a maternity CQC inspection, and we're still awaiting the report from that to come through. We're hoping that we will receive that in the next few weeks, and that's on the back of all of the Ockenden reviews that nationally all maternity services are having a CQC inspection. We continue to have a healthy incident reporting culture, and I think this is really important around ensuring that we're appropriately reviewing, reporting and investigating, and ensuring patient safety is high on the agenda. We've also are responding to the new national implementation of patient safety incident response framework that is going to come into effect from September, and that replaces the serious incident framework that we currently have. Fundamentally, the plan is that it will hopefully help improve and increase focus on learning and improvement, as well as ensuring that patients and their families are at the heart of the response, so making sure that we're learning and engaging with those. We have, as part of this programme, recruited 2 patient safety partners, and they will be present to make sure that patient voice is at the heart of what we're doing. We have reported a high number of patient satisfactions despite the increasing demand on our services, and we are currently looking at some improvement projects around patient experience and engagement. Part of our people plan, our people together, we're continuing to develop our staff networks and supporting the Black, Asian and other ethnic groups and improving their experience, and also ensuring that we're engaged with the different abled and LGBTQ+ staff as well. In relation to our quality priorities, you will see that we've made some progress in the improvement and management of pressure ulcers. Also, we've introduced new training for staff around managing physical violence and aggression. We've seen a really positive progress in the reduction of falls, and also around our management of falls across the inpatient ward areas. We still have a number of areas of work that we continue to review, and this is around the improving patient experience, but also around improving population health and how we can ensure that we're linking in with community programs, especially around obesity and diabetes. We have participated in a lot of national and local clinical audits, and you can see in Appendix 2 and 3 what those audits have been and where we are with those. We have had over 81 local clinical audits reviewed during the last year. And also, again, we obviously have a vision to ensure that we're participating in research and innovation, as this is integral to the functioning of the trust, and we're working with staff and patients to improve the health of our local community. We've also got the research and innovation team have been successful in supporting a number of key research projects, one of them being the Verbo, a speech and language therapy innovation project, which is now marketing to educational customers. So there's been real innovation in some of our research projects. As I mentioned, we haven't had a CQC inspection since January 2020, but we are awaiting the report from our recent maternity CQC. Overall position of the trust remains good, with the hospital site, as you know, achieving outstanding. The other key areas that I just want to obviously pick out is around learning from deaths. We've got less than 1% of patient deaths that reported were judged to be more likely than not to have been due to problems in the care provided. All CESD 1 scores or above have a multidisciplinary forum review, which is clearly good practice, but also any of our CESD 2 cases are reported as SIs, and we had no reported CESD 3 cases during the last year. The key is the multi-professional working and learning in relation to all of our CESD scores. I've already mentioned the 7-day service. We continue to meet the 4 priorities that have been outlined. We still have some future plans around that will be guided around national directives to determine what audits and reviews we need to undertake moving forward. And our Speak Up Safely, obviously, as you know, we've got a Freedom to Speak Up Guardian in place, and we continue to ensure that staff can raise concerns informally and formally, and making sure that feedback mechanisms are in place to ensure that we're protecting staff, those staff that are raising concerns. We've also recently recruited a number of Freedom to Speak Up champions, and these are individuals that are from some of our staff networks that are based across the trust to help and support our Freedom to Speak Up Guardian. We continue to ensure that we've got the accessibility to the Freedom to Speak Up, so that raising concerns at work is a key area so that people know how to ensure that they're raising their concerns. But also we've introduced a new reporting system on Datex, so when people are reporting incidents, if they've got concerns, they can raise it through that forum, and that's a confidential link as well. In relation to our proms,
I've got members who probably want to ask questions. Could I just ask you just to wrap up, so I can just go to questions?
So just the last one is around the patient-related outcome measures, just to say that obviously we continue to report on that. There isn't anything significant to say on that. And finally, I think the one other thing that we need to just mention is around the trust attributable C. diff cases. We had a threshold of 19 this year. We had 16 trust attributable cases. All of these have post-infection reviews, and one reported had a lapse in care. All of the rest, there were no lapses in care identified. And I think I'll just leave it there, if that's all right.
No, that's very helpful. Thank you for a very thorough report. Just before I throw it open to questions, Patrick, did you want to make any observations, or can I throw it open to questions?
If we can refer it to questions, that will be absolutely fine. I think Breeda's done a grand job of kind of giving the overall summary. So let's take it straight to questions, and I'll hopefully try and respond if I can.
Yeah, I think just so you're prepared, I think there might be one on the St Leonard site and where we're up to there. But just before I pass the Cllr Adams on that, Breeda, sometimes on the CQCs you get some initial feedback. Was there any initial feedback on the maternity? Question 2 was, even from my day a number of years ago on the Council of Governors at the Homerton, staff reviews and appraisals was always historically a challenge in terms of falling below where you wanted them to be. So where's that level? What number, what percentage of staff are receiving a review annually? And also in terms of the 4-hour wait, to what extent is this because you're undertaking mutual aid for other hospitals outside outside the area.
Okay, I'll try and do my best to answer some of those. I may not have specifics in relation to our appraisal rates, but we can make sure that we share those, but I know that they're improving. In relation to the maternity CQC, so we had verbal feedback after the inspection on the day, and at that point, they gave us high-level feedback in relation to 3 areas that we needed to look at. There were no regulation notices that we were informed of, and overall the feedback was quite positive. But clearly, you know, we need to wait and see what the official report says when it comes back to us. But on the day, we were happy with the feedback that we received. In relation to the staff reviews and appraisals, it's a bit like our statutory mandatory training. These are 2 areas that we continue to ensure that we're trying to drive forward. Our improvement, the rates have improved over the last number of months because we've had a real effort of trying to drive those. I think overall position, I think Bas might be able to correct me, but I think it's in the 80% mark plus. Our aim is to get to, if we can, obviously we want all staff to have their annual appraisals, but there is a positive trajectory and that's good in relation to both Statman and also our appraisal rates. In relation to the 4-hour wait, as I said, I think it's multiple complexities. I don't think it's one specific issue in relation to the mutual aid. I think, you know, it's multiple things around the acuity of the patients that are coming in, the fact that, you know, we've got delayed discharges because of social care issues, and I think it's multifactorial rather than one singular issue.
Okay. Thank you, Breda. I've got Councillor Adebayo, but before that, I had Councillor Adams who flagged a question, I think, to Basilic on
St Leonard's. If there's, if you can give us an update whether what's going to happen to the St Leonard's. And my second question is about backlog for elective healthcare. If you could tell us whether you still have anybody waiting for, the number of people that are still waiting for elective care from backlog.
So, Basilic, do you want to do St Leonard's, and then maybe, I don't know if Breda would probably best to do the elective care question.
Yeah, so just going back to the appraisal, we've hit our target for the first time last month. So we were about 86% compliance against the target. Well, I think it was 85%, if I'm wrong, Breda. So we've hit that target for the first time. So really great effort by everybody in spite of all where we are in terms of the strikes and things like that. So good work to the team. I think on St Leonard's, I'm still getting my head around where we are in terms of the St Leonard's site itself. I spent the morning with them about 2 weeks ago, just getting my head around where we are at the moment, the teams that are working there. What I can say is that continues to be, certainly from our trust board and those that I've spoken to, a commitment to running services in St Leonard's. There is a piece of work to be done, I believe it is, with NHS properties and across North East London itself around how we get investment into that St Leonard's site. I've recently just joined the North East London Estates group meeting. The first one, I think, is next week, and we will work together as a system around how do we get a really strong plan around St Leonard's itself. So I suppose in short in saying I'm on it, but there are still conversations.
We lost that
I need to buy the bin, spending the time with the team out there.
Thanks.
Can you hear me?
Yeah, we can. We lost you halfway through, but we got the gist. We got the gist. Breda, can I just go on elective wait? Post-COVID, have we largely cleared that backlog now? Is there anyone waiting more than 12 or 24 months on electives?
So I probably wouldn't be able to give you the exact figures, but I think we need to recognise clearly with the recent industrial action, it has impacted our elective activity. We have tried to ensure that we make sure our priority 1 and priority 2 cases, so our cancer waits aren't an issue, and they are scheduled. But I think we have to recognise that there has been an impact because of the industrial action and some of our elective activities. So that will impact our figures. But, I haven't got the exact numbers of where we are. But I know that we had made real progress across all pathways. But I do think that some of those pathways will be affected now because of the recent actions.
Councillor Adebayo, and then I've got Councillor Patrick.
Oh, thank you so much. You've asked one of my questions, which is about the CQC, because I really want to know where we are with the CQC, but I think that has been answered. But just a quick observation. Last week, I visited my GP, and after that, I received a text about the service provided. I think that was very good, because it gives the patient the opportunity to give feedback. I just want to know what will be done with the outcome of those feedback. Will it be collated, or is it peculiar to individual GP?
Councillor Adebayo, if that came from your doctor's surgery, that would be more the primary care aspect rather than Breeder at the Homerton to be able to answer that. But what we can do is maybe if you let Jarlath know maybe which surgery it was, and we could ask the primary care lead as to how that survey data is then fed back into results. We can deal with it that way. Have I got it right? The text was from the GP, not from the Homerton.
Yes, from the GP.
Yeah, fine. So I think what we'll do is we'll feed that back through Jarlath to speak to Kirsten, who's the GP lead at Hackney Place level, to find out what happens to that feedback data. And I think Breeder went as far as she can do on the CQC of the maternity. Breeder, are you expecting another more hospital-wide CQC, or are you sometime off that, or haven't you got any idea?
I think it's very difficult to say. Clearly, the system and the structures of the CQC are changing. I think there'll be a lot more kind of information requests and more specific led inspections rather than a whole trust inspection. So we would expect potentially they would come and review one service rather than a number of services like they've previously done, and they'll be using information and the intelligence to determine if they need to come and do a review. So I think the way the CQC are kind of evolving in the new era, it will look slightly different, but I still think the CQC are still in that transition as to how that will look, but we would expect more of a kind of a singular approach rather than an across trust-wide inspection.
Thank you for explaining that. Councillor Patrick?
Yeah, could I ask about the mental health services? I see there's been an increase of people turning up at A&E with mental health crisis. I just wonder how you're working with the specialist services and whether there's been a breakdown between the Homerton and the specialist mental health services and the council, and how we can all work better together to support people who are in mental health crisis.
Yeah, I think Bass will probably come in here as well. We just had a meeting this afternoon internally around mental health. I think there's been a huge amount of work and a huge amount of progress in relation to the management of mental health patients in ED. It's been very much on the agenda and continues to be on the agenda. I think, we are aware of the significant delays for our mental health patients in ED. We know it's not the right environment for them, but I think there has been a huge amount of work, and there is a number of projects across the system looking at how we can support. That includes looking at crisis cafes, ensuring that there is kind of urgent responders and multiple more community services, and that will help prevent the number of patients presenting to ED in a crisis needing that kind of support. So I think it's work in progress, but I think we as a team, an acute team at the Homerton, feel that there's been real engagement and definite progress in how we're collectively managing our mental health patients. So we never feel very much as an independent provider here. ELFT are very much on board. There are multiple forums now which we're all feeding into, and I think that's what we're trying to make sure that we're pulling all of that together. So I think we can definitely say there's real progress. There clearly needs to continue to be more progress, but I think it's going in the right direction.
And we're going to, our next item and last item is on part of that mental health issue. I've got two further questions I will bring it to Cllr Turbet-Delof.
Yeah, so it's just actually on mental health, thank you. I just wanted to check something. It's really great to see that there is the 4-week and 18-week target met. It's really, really good to hear. I wanted to know, because on the IAPS and talking therapy live data, it shows that there is a large number, at national level, a large number of dropout rates from those that are going through referral to those that complete treatment. What is the situation in the Homerton? Is it possible to know those data or that information? That would be really helpful. Thank you.
That would be something that we would have to be able, we would provide. I wouldn't have that information to hand, but I'm sure that's something we can provide.
Yeah, no, if you could, I would. Yeah, exactly. If you could, I think, from recollection, IAPT in Hackney is commissioned by the Homerton, isn't it? So it's a commission fairly by you. So yeah, that may be something you can send through. I had a question from Cllr Adams, and then I think there was a further question here. Sorry, I don't know your name.
Oh, Sally.
Sally, of course, Sally. Sorry, Cllr Adams.
Yes. Thank you. It's good to know that Mary Seacole's got a overall rating of good. I'm just wondering, what do you think needs to be done for them to get outstanding?
I think they haven't been inspected again, so they were hoping that they would have been inspected sooner than this to get the outstanding rating. I think, you know, clearly that's the position we want them to be in, and that's what we'll continue to strive to ensure we're delivering an outstanding service to our residents at Mary Seacole. So, you know, if we were to be inspected in that area, that's what we would be hoping we would achieve, and that's for all of our services. You know, that's what we're trying to achieve for every service that we deliver. So I don't think that, you know, that there's not something we're not doing. I think if CQC were to come in tomorrow, we would hope that we would be getting an outstanding rating for Mary Seacole.
And lastly, apologies, Sally, it's seeing people in the flesh. Sally, Healthwatch.
I just wanted to quickly go back to the St Leonard's comments, because, as you know, Healthwatch Hackney is particularly vested in the St Leonard side. Just to say, we are just about to publish quite an in-depth entry review report, and it was really clear from the positive feedback that we got how valuable it is to the people that are using services there. And I guess just to say that we've got a little pool of our resources that I'm keeping reserved for the point when it feels really valuable for us to do some engagement around the St Leonard's site. We're really keen to be involved in those conversations, but also equally really keen to make sure we're involving local residents' voices in those conversations. So I'm holding it back, and when it feels like it's the right moment, do come to us and we will do that work to find out what would be helpful from a resident point of view around St Leonard's.
Thanks, Sally. I think I'll take that as a comment. I think Buster heard that, and I think it may be that once that's further developed on the estate strategy, it's maybe that the good cooperation that's been existing between the Homerton and Healthwatch, you can maybe utilise that in terms of patient feedback at an appropriate point. So I'll take that as a comment, and hopefully that something can move forward on that at the appropriate point. I am going to close this item. So thank you, everyone. Thanks, Breda. Thank you, Buster, for your hard work. We're very proud of the Homerton and everything you do. And it was also there was a lot there on improving patient safety in your on your report, which I noted, and we're grateful for the hard work that you continue to do for the borough. So, thank you both very much. And with that, I'm going to close that item and bring us to item 6, which is the implications of the Met's announcement of bringing in a policy called Right Care, Right Person. This, I think, is intended at the moment to come in at the end of August, and in true terms, as I understand it, means the Met will not be necessarily responding to all mental health related inquiries that they were previously doing, and that obviously raises concerns in terms of people falling through the net, triaging, putting pressure on other services, and the short period of which they've announced they're going to bring this in. So we're joined by Georgina Diba, who's our Adult Social Care Director of Operations, Nina Griffiths, who's our Director of Delivery, and Jed Francique, who's our Borough Director for City of Hackney from L. Georgina, do you want to start off? Thank you for the succinct and helpful presentation, and we appreciate things that are still in a state of flux as you are trying to get to grips with exactly what will be the policy from the Met and how it will be enacted. But could you give us an overview of the latest understanding?
Sure. Thank you, Chair. So this really is a fundamental change to when the police will be deployed, and we will be speaking a lot around mental health, but I just want to highlight actually that the model, which was first implemented in Humberside, didn't just apply to mental health or mental health crisis. It also applied to where there were concerns for welfare. So, for example, it could be an adult who had dementia, where there was a walkout of a health facility, so where someone may have gone into A&E but had chosen to leave. It does have implications for children and young people, including children and young people who might be in mental health crisis. And of course, as we're going to speak quite a bit to around those under the Mental Health Act under Section 136 in crisis or in respect to transport. So there is, in the main, our information at the moment is coming from the Humberside model, and really information that's really accessible to members of the public. So we don't have a huge amount of information from the police at this time. But what we do know is that they want to build on the Humberside approach across London, and they are hoping to do that by August 31st. Now, we were only informed of this, unfortunately, on the 24th of May. So one of our primary concerns has been a really short lead-in time, 13 weeks. And this model took about 3 years in Humberside to implement in a really kind of phased way to make sure that people are safe. As I mentioned, this is really about the triaging. So the intention is to train up the call handlers so that they're making decisions around who is the best person to be deployed in order to support an individual. Now, I have to say, as a partnership, it's not that we don't agree with the approach. We're very keen that when a person is in crisis or in need, that the most appropriate person is there, whether that's health, social care, police, etc. But again, it's just about making sure that's done in a way that is safe and that we as a system can respond to. I believe we are worried as well about the financial implications in terms of implementing this model in a really short period. There may be costs associated with additional dedicated staff, particularly in our local crisis suites. Costs associated to local authorities around the demand in terms of Mental Health Act Section 136 detentions, as well as impact on the LAS. But I'll come to that because there's actually been some progress in the last week since I wrote the briefing note. Within Hackney, we do have a partnership set up and ready to start responding and looking at how we can change our approach. And I'm really pleased to say that the police are now attending that partnership meeting. There will be 4 different groups, operational groups, which look at the key areas that we feel there are risks. That's in respect to the mental health and crisis pathway, in terms of how the police respond to children and young people, those missing from hospital, and finally the welfare and missing in community concerns that are raised as well. There have been conversations held at the local level between system partners and the borough commander. There was one in the North East London ICB, as well as one being held between the borough commander and the group directors for both children and adults. These were really positive conversations, but very much looking at the system pressures and that we need to work together to achieve outcomes for individuals. So the most recent update I have from the police last Friday, there has been a partnership board meeting held at New Scotland Yard. And this looked at the principles of the right care, right person, the current health demand placed on the Met, and the legal obligations of police and health services. There is support for the principles of the right care, right person, but the go live date of the 31st of August was really concerning for all partners. There was a further meeting last Tuesday, and it was just going into more detail around the 4 kind of areas being data, decision making and process, operational best practice, and training. So there's been a few updates from partners, including a commitment from health partners to aim for pan-London policies for concerns for welfare and missing from health establishments. And the LAS, London Ambulance Service, are procuring a process for 14 new mental health ambulances over the next 2 years. So there has been some progress. There's expected to be, again, across London, a programme of work by early August. And then we'll come back together to look at how we are going to implement that locally and any changes. So there is clearly some good progress happening in the area.
So Gina, are they still working towards the 31st of August go live date?
That date hasn't been communicated as changing. However, I think there's absolutely recognition. It took 3 years in Humberside. There's been 13 weeks given for London. Partners across the entire system from every organisation has raised concern about the very short timescale for systems and partners to be able to respond to the risk. And I think locally from our police, they are clear that they will continue to go out and be deployed to support those when they're triaged to do so. So while there hasn't been a change, I believe on the 4th of August at the next Partners Board, chaired by Matt Twist, there will be a discussion on the go live date.
And I mean, has representation been made at London Council's level to Deputy Mayor Linden and Sadiq on this or not? I mean, is there enough political clout going to make representations?
My understanding is every organisation has raised concern about the timescale. Okay.
And Nina, presumably the mayor's being briefed. I mean, is there a case that more political clout is needed to escalate this, or is that already being done from your perspective?
Thanks, Councillor Hayhurst. I think a lot of escalations have been made, both through the kind of social care route, ADAS, through the ICB, and also through political routes. I think one of the really positive things I would say is that in discussions with police locally, they are really, really keen to make this work. And I think they also recognise that the timescales are probably unachievable from the police side. So I think we should wait to hear an update. I think for us, the main risk is around the timescales. And I think significant escalations have been made around that. And I think we should wait to hear an update from the police around a realistic understanding from them of likely timescales before we push back with further escalations.
That's helpful. Thank you. Thank you. I saw a photo of you. I sort of cut you off, just trying to understand. Do you have anything further to add, or shall I throw it open to any further contribution on this from anyone else? Jed, do you have any contribution?
I mean, the only thing really I wanted to emphasise was that the partnership group that Georgina has pulled together, which Health is a part of, and the police have just joined, is obviously a very good vehicle for responding to the issue at hand. And obviously the Health is actively involved and committed to help to find a partnership solution. So I think that's the main point I wanted to emphasise.
And presumably at some point this could possibly, I don't quite fully understand how the Humberside model works, but it could involve health with a combination of health partners providing a more emergent, I mean, it's at price FAs, but essentially providing a more immediate outreach response to situations is where this could possibly end up.
Yeah, I mean, it's fair to say that, I mean, it came up in a previous part of the meeting where it was discussed that the issues in relation to people presenting at emergency departments, for example, multifactorial. One aspect of that is what we can do to provide more support in the community to meet needs in the community upstream. So that's clearly part of the solution, and that will involve us working with partners, voluntary community sector and others. So yes, there is clearly that is part of what I think will happen. But there's a number of different elements that are being discussed in relation to respond to the crisis, developing the crisis pathway, including more diversionary activities, looking at bolstering the crisis line, crisis hub activity. We heard about the strengthened liaison work with Homerton, so there's a range of different factors. But going to your point, clearly part of this is upstream work and trying to kind of shore things up in the community so people don't need to go to ED in the first place, or there's less need to go to ED in the first place.
Thank you, Jed. Members, do we have any? Chris.
And just to add, I think you heard a little bit about it at the joint Elbow scrutiny for in North East London, but in partnership with ELF, the City of London does commission a street triage service, which has been very successful, which will be evaluated in public health, and it provides one of the potential opportunities. It is an expensive service because essentially it does provide specific mental health outreach workers who are based in the police station in the City of London. I think that model is a model that has been, interest has been expressed from the ICB to look at it across the whole of North East London, and potentially there would be economies of scale from doing that, because the nature of a mental health crisis is that it may not happen every day, but you need the capacity there. So that service and the evaluation we've got, and the fact that ELF are the provider, I think does offer potentially an interesting model that the Xenocook has already expressed interest in potentially, rolling out.
Expanding out. Just for those members that aren't aware, our public health team are also a public health team for Hackney and the City of London. So, but out of interest, because what has been, is it crudely, is it money why that has been in the city and not in Hackney as a service? Because that service is often touted. What's the reason why an analogous service has not been across Hackney?
I mean, because this is a public meeting, we always have to be very careful about how we refer to people who come to take their own lives. And so suicide is something which, any area which has very large buildings, for example, and the reporting of people who are potentially going to take their own life often then leads to other people coming to an area. So the City of London has got relatively high rates of suicide in the past, with people that have actually been, the police have identified and have intervened with. So I think that's why particularly the City of London has had the service first. As I said, the evaluation did prove it to be effective. It's not a 24-hour service because during the daytime you've got your standard services, but in terms of the benefits that are there from embedding more mental health workers with your police service, certainly for the unique situation in the city, it's been very successful. I think there is a good model that you could then look to roll out. I think the issue is going to be timing, staffing, and resources.
Thanks for explaining the sensitivities of that, Chris. Nina, and then I'll ask members. Nina?
Yeah, I mean, linking to what Chris Lovett was just talking about around the street triage model in the city. I think the kind of overall what the police are kind of presenting to us is you can see that this could be an opportunity to really think quite differently and better about how we serve and respond to some of kind of key incidents of mental health crisis in the community. And I think in the long run, we could think quite differently about how we respond to those mental health crises more appropriately and with more trained or appropriate healthcare staff. So I don't think that's kind of in principle the wrong thing. The risk that this faces to us is, one, the timescales in which it's been presented to us, and two, our ability to kind of find the workforce and the resources to develop those new pathways and services in this new model. So I think it's that timescale risk is the biggest one. Street triage is a model that we should be considering. It wouldn't be exactly the same as the city model because the geography is very different of Hackney, but something like that should be something that we could consider. We also know that London Ambulance Service currently run a number of mental health cars, and they've been talking to the Met Police on a pan-London level about expanding that provision of mental health cars as well. So that's another potential avenue in response to this.
Thank you, Nina. Members, Councillor Adams?
Yeah, my question is around the financial implication of the decision. You talk about Dr. Andrew, yes? What's the name? Yeah, Chris said, talked about extra resources. Where is this extra funding going to come from?
And just before resources, Cllr Turbet-Delof, we're running out of time.
Yeah, actually quite similar, but I wanted to say that I wanted to ask, now when the program is rolls out, do we have an idea of what we expect as demand when that comes into place, and what sort of staff do we have, or members of the staff do we have to cater for that demand, and that will be on each council and boroughs. Thank you.
And just as I'm taking your questions just because of time, Cllr Binnie Lubbock.
Yeah, just very quickly, the reports that we've seen on the Humber side, obviously they talk about a reduction in police hours for this kind of work, but they don't talk more broadly about the outcomes for the public, other services and individuals. So I'm wondering if anyone has any insight to that about how that was, obviously over a longer timescale, how that worked out.
Thank you. And just before I go to answers, any more questions? I'm just closing up here on this item. No. Okay. So thank you. I think finances maybe Nina. Demand staffing. I don't know whether Jed, you might be best placed to sort of as best you can sort of about what extra resource might be. And I don't know who would like to have the representative comment about the outcome review of the Humberside model. And then I'll wrap. I'll end up with Sandra. Nina, do you want to go on finances first?
Yeah, I mean, it's an easy answer. There's no specific additional resources for health and care services to respond to this, which is part of the challenge. And I think that's essentially is the challenge. So we need to be thinking about how we can support this change out of existing resources, and or how we could build a case for putting resources against this if we could also evidence improvements in outcomes or efficiencies in other areas from doing that. I think that's one of the fundamental challenges that we have with this at the moment. What we do now, I talked about the London Ambulance Service and the mental health cars. They are resources that we currently have, and we know that the current mental health cars that we have in North East London are underutilised, so there may be scope and capacity for better utilisation of that service. And we know that there could be more capacity there that we're not using.
And Jed, have you got any further comments on the staffing side or demand?
I can't give a definitive answer. I mean, the reflection I'd give is that whilst people in mental health crisis is only one aspect of what we're talking about, there is an upward trend in terms of people presenting with mental health crises, for example, to emergency departments, and the police accompanying them is a significant portion of that. So, for example, in May, there were 451 in total presentations to Homerton ED people with mental health crises, and that was 50 more than a month before. It's the highest figures we've had. So, in terms of the demand and the constant staffing implications, I can't give a definitive answer, but I can say that there's an upward trend in terms of people with mental health crises that need support.
And is anyone looked sufficiently into the Humberside model to see whether there's been any peer review on outcomes for the public?
I can answer that. I have had a look. There has been nothing around outcomes for the public yet shared. I think it's something we're definitely interested in looking at. But I guess I would say, you know, based on the model, having the right person attending to you, based on kind of whether you're kind of lost or you're missing or you're scared or you're in a mental health crisis, again, it's not the approach that we're disagreeing with. That might be better met by a healthcare professional or a social worker or even a care worker if they know you and you're confused and missing. But definitely it's not something that has been highlighted in the police findings, but something that we would want to track in terms of any changes that we make if it's making that difference for people.
Thanks, Georgina. And lastly, Sandra.
Yeah, thank you. Just in terms of the outcomes, I'm not particularly familiar with the Humberside model, but both from the model that we have in the city and also a slightly different model that operated in Southwest Wales, where there were trained mental health workers in the police call centres and advising police over the phone, as well as directing particular responders, but all from the police to particular calls. The outcomes were better for patients, that they were less likely to be held under a Section 136 of the Mental Health Act, and they were more likely to end up in the right place with the care that they needed. And really significantly, people in mental health crisis will end up not being taken to a police station as opposed to a place of healthcare. So the certainly the initial outcomes for the people involved are better. So from both models, actually, we can also we've also been able to determine that there's a benefit to the NHS, and in the South Wales model, they actually ended up saving NHS money, but the police paid for it. So the reason I'm bringing that particular example up is because I think that it may be something to throw into the pot in the negotiation with the Met about how to smooth the transition if they end up freeing up some resources by changing their practice. Then as the savings accrue, if that's the right way of putting it, to the NHS, then the resources can be reconfigured to enable the long-term approach.
Very thought-provoking and helpful as always, Sandra. Thank you. Thank you. Well, with that, I'm going to draw that item to a close. I think it's an obvious item to ask to come back when matters are further progressed. So I think we just need to keep in contact with Georgina, Jed, and Nina as to when the best time is, because I don't want to bring it back prematurely when still going on. But certainly need to get an update as to how it's panning out. It may be something just before the end of the year, even just briefly, just to understand where we're at, and whether it's that end of August deadline ended up being softened for a greater transition period. But thank you all for the update and your comments on that. So I'll bring that item to a close. Item 7, minutes of the previous meeting. Can they be agreed, please? Agreed. Item 8, lots of very helpful suggestions to the work programme from a host of different partners and members, so we're grateful for those. Giles and I will be discussing those and maybe put forward a suggestion at the next meeting to members as to key items we can do going forward. And I haven't been notified of any other business, so with that I will close the meeting. Thank you, everybody.
Okay.
Thank you.